Good morning.
Well, good morning, everyone. We're going to get this meeting started. We have a lot to cover this morning. I am Marty Marin, and this is my wife, Michelle, and we manage Trio Maryland. So if you have any compliments at the end that you want to send out, please let us know, and we'll give you our address. We'd like to welcome everyone today, especially the members and our guests that we have not met before. We're really happy to see your face this morning. We really hope that today may not be your only meeting that you attend. So check us out. We have a great schedule. It runs throughout the year. I'm sure there's other topics that you could use. Today's meeting addresses the risk of cancer post-transplant. And today is a really great day because it features Trio National's president, Jim Gleason. And Jim's not just our president, he is also a heart recipient. So he has also lived it. And he has brought along with him Dr. Mark. He is a dermatologist from the Philadelphia Mohs Surgery Center. So he will be here to help Jim with any questions and concerns that you might have. And one thing before we officially get started, I hope everyone has been watching Facebook and that and looking in your mail, but Trio Maryland is going to be hosting its first virtual transplant conference. Going to be very similar to our live. We're going to offer 7 different topics. The conference will run from 9 to 12:30 Saturday morning. And if you haven't seen the post, just go on our website at www.triomaryland.org. And the very first page you run into will go through what it is all about and the speakers that we have coming to the conference. At this point, I'm going to turn it over to my beautiful wife, Michelle, and she'll carry on from here.
Hi, good morning. Before we get started, just a few housekeeping notes. As far as your questions go, please type them into the chat feature of Zoom. And if they're not answered during the presentation, we'll address them at the end. Everyone needs to be muted. If you find that you're not muted, that I didn't mute you, please do so yourself. And I appreciate you helping me out with that. Today's meeting is about, and this is so important to all of us transplant recipients and their spouses, successful living in spite of a higher risk of cancer post-transplant. Our speaker again is Jim Gleason, the president of Trio National and a 27-year survivor of a heart transplant. He also has brought with him his good friend and colleague, Dr. Mark Abdelmalek. He's a dermatologist from the Dermatology of Philadelphia location. It's a Mohs Surgery Center, and Marty's had a couple Mohs surgeries himself, so I'm guessing that maybe a lot of you are really familiar with what that's all about. So we're excited to have Jim and Dr. Mark here, so welcome, and we appreciate you addressing our group, and we're going to turn it over to you. Thank you very much.
Welcome, everybody, to a very special meeting talking about a very important topic. We're going to be talking about the higher risk of cancers and guide you through a series of supporting slides. So as Marty said, I'm out 27 years with my own heart transplant, and I've dealt with several different types of cancer, prostate cancer, kidney cancer, and many skin cancers over those 27 years of life, 21 years dealing with those kind of cancers. And so today, we're going to give you some background on how Trio got into this cancer business, why it's so important to you, and look at overall project plan and timeline, along with reemphasizing the overall message, which we repeat several times so you can't forget it. And the main part of this will be a tour of that resource, the Post-Transplant Cancer, or PTC, website. We'll summarize some takeaway points, offer you a personal challenge, and then we're going to have Q&A with a very special guest. Dr. Mark is a highly regarded, honored, board-certified dermatologist in the Philadelphia area. He is a skin cancer surgeon that specializes in Mohs surgery, the precise surgical removal of skin cancer with expert reconstruction. And that's important because sometimes when you get these surgeries done, you have to go to somebody who's going to do that reconstruction separately. In this case, he takes care of that, as my own dermatologist does. Mark is also an award-winning ABC News reporter. You may have seen him on TV. And he's the founder of the Dermatology of Philadelphia Mohs Surgical Center. What's really special about him is clinical interests are caring for high-risk skin cancer patients and comprehensive skin for organ transplant patients, our topic for today. Mark, we'll get back to you. So why is the topic so very important to you, our viewers? Studies show that cancer is one of the leading causes of death post-transplant. Transplant recipients, like ourselves, are at higher risk for cancer, in some cases more than 50 times higher than the general population. And within that general population, different categories of people are more sensitive to cancers than others. Patients are often not getting long-term follow-up counseling on this issue, especially in the kidney world, where so many kidney recipients are in large programs. They get passed back for the follow-up long-term care with their family doctors or a local nephrologist who's not very focused on the risks that come with cancer in post-transplant years. But with education and proactive follow-up, we can recognize early on and treat and cure cancers, and thus living long and active and healthy lives for those many extended years with our transplants. So our goals for today, very simple: raise your awareness of this post-transplant cancer risk, show you how to use this TRIO web-based resource to learn and commit to best practice actions in dealing with that risk, and finally to provide some basic education, answering your questions of the key areas of post-transplant cancer concern that come out of our research and findings. The main message, again, is diagnosing and treating cancer early results in long, healthy post-transplant lives. So where did this all start? Well, back in early 2014, I got a call from Steve O'Connor, the president of our San Francisco chapter. His message was, "We just lost another San Francisco chapter member to cancer. What do we got to do about that?" I laughed. Yeah, right. What can we do about cancer? I totally dismissed Steve's seemingly impossible question. But after I got off the phone, I thought about it. I said, you know what? I called him back and said, okay, wise guy, if TRIO can't do it, who is? If you're game, I'm willing to see what we can do about cancer. And thus began this TRIO post-transplant cancer project. We didn't know what to do. So the first thing we had to do is find out what kinds of needs are there and how we can address them. And we end up putting together a plan of a 5-year project plan for this. What really was our plan turned into the reality of a longer term plan to finally get it done. Funding sort of dried up in the middle years, and so it became fundable in the last couple of years, and we finally got it finished. And so as we then got into it, we focused 3 key points in that whole website: understanding the higher cancer risk post-transplant, recognizing symptoms, and taking action to live with the higher risk of cancer. But the most important issue, the one I challenge you with, is changing human behavior, our habits. It's one thing to know about it, but what are you going to do with the information you've got? Let's stop here. And I'm going to ask you a question. We're going to do a poll, and you're going to enter the information into the chat session of this webinar. And then Michelle will report later on your responses. So when were you made aware of the higher risk of cancer as a transplant recipient? In the chat session, put 1 if during the pre-transplant workup process. Put a 2 in there if in your post-transplant you found up the follow-up, during the follow-up process you've learned about this risk. 3, when you were diagnosed with cancer. 4, I was never made aware. Or 5 would be other. And so Michelle will keep track of your responses. We'll hear about that later. Let's look at the site structure of the website itself. The address that we're going to repeat throughout here, so pay attention to it, is TRIO Web PTC. PTC is post-transplant-cancer.org. It's also linked for our main site, which is trioweb.org. The site consists of 46 pages of post-transplant cancer, PTC topics, but on average, visitors such as you would only select about 7 pages of interest to your unique personal life journey. So it's organized into 4 main categories under the letter L: learn, look, live, and links, where learn about the facts of cancer risk by type of organ transplant, look for cancer symptoms, live proactively to prevent, diagnose, treat, and live long with that cancer risk. And finally, stretching it a little bit with links. These are links to the online resources to support further learning about post-transplant cancer. live, proactively to prevent, diagnose, and treat cancer. And finally, stretching a bit to the links to online resources to further support learning about post-transplant cancer. We're going to visit each one of those individually, but here's the big picture. The schematic map that was used to design the whole website. So you had color code on the left, learn, look, live, and link. Learn, look, live, and link. And then across from learn, you have the sub-elements of different organ types. And then finally under look, you have different types of common cancers. And number live, those 4 phases of living with it, and then extra resources to help go further. And so first goal was to make this more user-friendly than that schematic. And so what we'll find is a tour of the launch website will show you exactly how you would experience it if you go there yourself. First of all, making it people-friendly. People's stories are used to illustrate successful treatment of cancer post-transplant, giving you the inspiration that, hey, it's not the end of the road. If you scroll down from the scrollable or the rotating people's stories, each of which has a link to their full story, by the way, you come down into an introduction for that particular topic. And once you get into that introduction, in this case, this is introducing post-transplant cancer in general, we get your interest and then take you down into a little bit more using the learn, look, live, links part to describe what you'll learn here about the cancer risk for your organ type, what cancer symptoms to look out for, how to live with cancers, how to build an action plan to help you manage your risk, and where to go to link for other helpful resources. Continuing to scroll down on that same page now, this is one page we're just scrolling through, you will then see, for example, some commentary by people that have used the website. And the one I like to focus on here is this one by a transplant surgeon. He wrote to us, "This tool is fabulous," and those exclamation points are his. "You will save countless patients' lives and empower recipients to take ownership of their healthcare and cancer mitigation strategies." And so that's what this is all about. Scrolling down further, we have some commentary by a medical copywriter about cancer in general. And the point is, it's every place. Cancer is spreading, he says, it's touching everybody's life, young and old. It's likely to affect the lives of your own family, yourself, your community, your friends. And so I ask you right now, think about it. Have you dealt with cancers? Has your family dealt with cancers? How about your friends, extended family, your church family, wherever, the community? And how many of those have you seen die of cancer? I must admit, I've had just recently, the last couple of years, my closest friends of my age dying of cancer. And as a transplant patient, I've dealt with those cancers because I have the follow-up care that's given by the transplant program. In some cases, they were so healthy, they never saw a doctor until they came down with cancer. And since they hadn't been followed and wasn't caught early, it became fatal in their particular lives. And so the topic interfaces are typically these icons that you see here. Here's one for heart, kidney, liver, and there's more of those. And so within Learn, those icons will take you to across that category that we saw in the schematic. Each page looks pretty much the same. It starts with an introductory text of about, one paragraph or two that's raising the topic importance to you. Now that we've got your attention and interest, there's going to be some short clips of interviews by some of our medical faculty, our medical professionals who have expertise in this transplant cancer world. And we've taken presentations they've done to support groups as an example, and we've edited out clips to match the topic of particular pages across those 46 pages. Their longer presentations, if you're interested in seeing them, are also, as you will find out, on our resource page. Their online resources are available in the long-term presentations they did, sometimes of an hour or an hour and a half, for example. And so if you're interested, you can actually see their entire presentation. It's available online in our TRIO transplant presentation library. We also provide then, now that we've interested and gotten you that far, more in-depth paragraphs of text information with some graphics to support that. And then we give you a chance to check your learning with interactive learning tools. These are engagement quizzes that give you a chance to pause and see if you've got it right. We are getting feedback anonymously from these quizzes. And so we're constantly checking to make sure that this page is providing correct information in an effective way. And so we can modify the page as time goes on if the results from the quizzes aren't what they're supposed to be. Secondly, they will confirm your correct answers and give you a nice score for that. Or if you get it wrong, they're going to give you corrective information and your scores will reflect that, of course. Then balancing the heaviness of the topic of cancer. We've interspersed, at the suggestion of several, some inspirational and motivational quotes to, as you're reading through this, you're getting kind of heavy with the whole topic, to give you some way of stopping and say, well, yeah, I can do this. And that would be followed by an action item section, which translates what you've learned into some things you can do about it. And finally, you want to learn out more about what's on this page. There are links to some more online learning. And so, for example, if you were to go to the Learn section, and then you would choose what particular organ type you're most interested in. And so there's a lot of repetition in these pages in any one horizontal path of pages. But you are only probably going to pass through one of these. And so you won't see that duplication, but the same information is important to all, even though it's tailored to that particular organ type. And so you would have that introductory text for that particular topic. Scrolling down from there, you run into the videos that I talked about. And then that overview section gets you a little bit more in depth, and then gets down to what is often a common set of topics for each page across that horizontal list. So what cancers am I at greater risk for and how is my risk? That's going to be on every one of the pages of the Learn section. So no matter which organ you're coming into, this page, this information is tailored to the particular topic, meaning your particular organ type, because it is different from one to the other. And so when you talk, for example, about why does the risk increase over as you're getting older, it goes up. And secondly, as you're on those medications for more years, it continues to go up. And so that explains a lot of it. And a majority of that is your meds you're on, but each organ type has a different protocol of meds. So that's why it's different no matter which path you take through here. And then we might run into an inspirational quote, for example. Here's one on this page. Everyone can be taken from a man but one thing: the last of the human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. Now, isn't that an important message as you're getting frustrated with thinking about living a life of cancer, and it's your attitude? And so then you get into, below that quote, an action plan. What can I do about what I've just learned? And then the suggested next steps. Now you do this, where do you go next? And then as you continue to scroll down, you get into that interactive learning tool or quiz. And this is testing your knowledge, for example, in this case, the heart transplant risk. And as I said, it'll correct wrong answers. It'll score you for positive answers that are right. And so with that in mind, let's stop again. Poll question number 2. Again, just type the number into the chat section. As a recipient, what type of cancer have you experienced since receiving your transplant? 1 is skin cancer, 2 is kidney cancer, 3 is liver cancer, 4 is blood and lymphoma cancers, PTLD, 5, none, fortunate people, 6, they don't know it yet because they haven't been screened, and 7 other. Just put your number in there. Michelle will give us a summary later on. And so the heart quiz itself, as you scroll down past that, you get to that related links section. And you're learning based on individual. And so we get back to the main schematic, and you see that we've come into the introduction section. From there, we've moved down to one section, talk about the cancer risk in general by organ type. And that in turn has allowed us to move even further after the first two sections down into picking a particular organ type. And so we would step down to that topic for your specific organ, such as heart, and that would take you down into the pages that we just described. Learning about the cancer risk topic for your particular organ, such as health. So you see how that works. Once you're finished with the learn, which may be just one page, or the general page and then specific page to your organ type, we're going to take you down into identifying the symptoms or tests you can do to catch cancer types early, the look section. So from the risk by organ type, we step down to cancer symptoms by type of cancer, skin, blood, kidney cancers, etc. Not all cancers have obvious symptoms. Some require preemptive testing. And that'll come out as we talk about how you're going to live with the cancer topics, okay? From cancer symptoms, we go down to that third level into living with a high risk of cancer. This involves prevention. How do you prevent? Get them diagnosed, treatment, and long-term recovery, all critical elements. And then here you'd run into another one of those quotes. Promise you'll always remember. You're braver than you believe, stronger than you seem, and smarter than you think. And hopefully with a smile as you look at Winnie the Pooh here, it'll give you that uplift you need as you're dealing with this kind of topic. With that, we're going to pause again. One final poll question. As a patient, how often do you get screened for cancer post-transplant? 1 is every 6 months, 2 is once a year, 3 is as needed, 4, I've never been screened, and 5 is other. Put that in the chat section, please. And we get down finally to the fourth level of information. From living with higher risk of cancer, we can link to other resources. These include patient testimonials, for example, the interactive blog, best practices people have experienced that give them best results despite the higher risk. What are the learning objectives of this whole process? Future insights into where we're going next with the research into behavior. How do we take people and guide them from moving from learning about this stuff to doing something about it? And so with that, we move into each one of these as an example. So first, let's talk about the patient testimonial videos. These are 3 to 5 minute vignettes of various patients with different organ types and different cancer types sharing their successful experience with them. Now, we all know that we're going to die someday, and that's why we got the transplant, to try and extend that life. And so you're going to find a couple of people here, if you happen to recognize them, realizing they have since passed away, but they left behind this inspiration. So Yushi, for example, at the time was the president of our Japanese chapter and shared his story. And over here, we have Ron Taubman, very active trio member out in the West Coast, and he died just a couple of years ago. And they left behind this legacy of hope by sharing what their life experience was like post-transplant, dealing with cancers. The learning objectives, why are you here? How does it make worth your time? Well, if you read this, you'll understand what we're trying to accomplish, and you can evaluate whether you got it out or not. And then we have behavioral research. This is, again, a future research piece, but we're trying to talk about how to take the education and add action to it to get the results of a long, healthy life. So taking the education, changing your mindset, providing the motivation to take action, and getting the results. And so that's coming, but there's still some information right there even now. Medical faculty, these are 12 so far medical experts who have shared their expertise in answering questions and recording those presentations, both in terms of excerpts on particular questions and as a presentation overall. And then we have the online research library, over 700 links to post-transplant cancer things that you might want to look at on the web. The first part of these are those full-length presentations that our medical faculty have done over the years for us. So here's where if you want to see what that doctor had to say beyond just the quote you saw on the particular page where you watched the video, this is where you would come. And so what we come down to now is how to use the learn, look, live, and links topics, how they all fit together into that big picture. And so the arrows indicate where we've just been, and made easier by this interface instead of that complex skeletal diagram. Along with those icons, you can also use the menu bar up top. And this has been a challenge. I tried to capture on these screens the drop-down menus. So for example, if you go to the Live section, along with a general, here's how to live with cancer risk, there are 4, 8, 12, 16 subpages, plus 4 other topic areas that take on each of those 4 areas we talked about. In other words, prevention. Under the general topic of live, there is the prevention group, and it talks about overall prevention. And then it gets down into prevention by different types of cancers, such as the most common one, and the one we have the most information on, is something that Mark's very knowledgeable about. That's the whole skin cancer area. And so you can find all this both on that special website that we talked about, but also on the main TRIO website. So if you did a search on TRIO, you'd come up with trioweb.org, and there at the navigation side, there is a link to this cancer website. So if you don't remember the second one, which is just an expansion of the main one, trioweb.org versus triowebptc.org. So just trying to make sure you are clear on what you can find there. So what are the key takeaway points from these 4 pages, 46 pages of topics and videos? As transplant recipients, you have to accept the fact that you are at higher risk for cancers. Once you accept that, now we got your interest. The main cause, which is always a question everybody asks, it's our life-saving daily immunosuppressant med. So you're not going to avoid the cause, although as you deal with some of these cancers, for example, and you go to that specialist, such as a kidney cancer specialist, if your kidneys are acting up, they will often recommend to your main transplant program, in my case, hearts, that they change the immune suppressant meds I'm on, because the original cyclosporin, for example, it was causing damage to the kidneys. And so they moved me over to Prograf or tacrolimus, and that has reduced the issue with the kidneys. By knowing your risk and watching for the symptoms and following preemptive testing, because not all the cancers have obvious symptoms. And often when I'm talking to people and they say, yeah, I've had kidney cancer, for example, I say, how did you find that? I mean, it's not like a skin cancer where you can see it. And each case, it's interesting. We as transplant patients have the added benefit of seeing doctors on a regular basis, being referred to specialists, and focused on the things that happen in our community. I've recently lost, and I count on 2 hands now, 6 of my closest friends for many, many years. I mean, one friend was my close friend for 72 years. They all died recently in the same age range that I am. And they've died from things like cancer. They were often so healthy that they didn't see a doctor. So how the heck am I sitting here 27 years later watching these people die? I'm actually out there reinventing my friend network, because the others are leaving. Even though they've led healthy lives, when it came time that they had to deal with cancer, it was too late, because they had not been doing any preemptive testing. They stayed away from the doctors. We don't get to do that, thank God. And as a result, quite often, we end up surviving longer than the person who's been healthy their whole lives, until they get taken down by one of these fatal cancers. And so cancer diagnosed and treated early can be cured in most cases, and with knowledge and action leads to long and healthy lives. And I'm sure every one of you has a story you could share with that. And so your personal challenge today, the more important issue is changing your behavior, forming healthy habits. And so when we look at best practices, you'll see what we're talking about. So use the TRIO post-transplant cancer web resource to learn, look, live, and follow the best practices under the link section. Again, diagnosing and treating cancer early results in longer lives. So here are the 10 best practices. We don't give advice. This is what people have told us and we've seen seems to be the keys to having a long and healthy life. First, and I'm just gonna, this is out there on the website, so I'm not reading all this, but basically reinforcing what we said. Understand and acknowledge that with your organ transplant, there comes a higher risk. Second, being proactive in prevention, early detection treatment is the focus of success. Know and follow scheduled regular testing that your program, if your program follows you, and this is different by organ types. Think about it. In a kidney world, a big program has too many patients to follow for a lifetime. And so as they continue to treat new patients, they're patients that have recovered and are doing okay, they move back to either a family doctor or a local nephrologist who may or may not be focused on the uniqueness of a post-transplant life. And so in a heart program, for example, like myself, or a lung program, the way I say it, they own us for life. And they're there all the time, making sure that we're doing regular follow-ups with a dermatologist, seeing care about the feet, for example, making sure you see an eye doctor, all those kinds of things that make it possible to catch things early. And so practice number 4, listen to your transplant team's advice, especially since they have a network of specialists who not only are specialists in their area of specialty, such as nephrologists, but they also are specialists not just in the kidney, but in the transplanted kidney world. That's the key. And so number 5, write down a few key goals you're willing to commit to from this best practice list and track the progress. As we say on this page, every day is a good day to be alive, whether the sun's shining or not. And sometimes we need that reminder. So throughout here, there's 46 of these motivational, inspirational quotes to support that and balance out the heaviness of the topic. Number 6, make sure you maintain full compliance with your transplant team's directives, especially relative to those meds. Don't let the expensive meds get in the way. Sometimes we get tired or choke on them and say, oh, I don't want to take this one. Do not skip those meds. Easiest way to get past transplant is to die from not taking your meds. Number 7, keep active both physically and mentally every day. I got to tell you, I get out of bed in the morning and the first thing I say to myself, I look down, damn, above ground another day. This is going to be a good one. And so that whole attitude makes a world of difference. Number 8, keep a regular schedule of appointments and testing. Don't bypass it. I've seen some of our heart patients, for example. I said, how'd you make out in your last annual? Oh, I didn't go. Whoa. That's the first key step toward losing what you worked so hard for. And then number 9, take a list of questions with you when you go to see that team. Let's face it, our memories don't keep track of everything we're questioning. And so you keep that little notepad handy. And when the question comes up, write it down, take it with you, and make sure it gets answered. And remember, number 10, you are the most important member of your medical team. As I often say, you're the only one on duty 24 hours a day, every day, who knows how you're feeling, even beyond what testing and your medical team can see and feel. And so be open, attentive. Most doctors let you bring a recorder in. And I got to tell you something. When my wife and I go into one of these meetings, we often have a conversation later and find out that we both heard directly opposite answers to some of those questions. Now, that can't be right. And if you have a recording, you can go back and see what was really said. If you don't have a recording, then you want to go back and say, hey, when we asked you this question, what'd you say, yes or no? My wife said you said yes. I said you said no. And with advancing age, that gets even more and more challenges. The other attitude I have is those doctors, we pay them. That makes them our employees. And if you're not comfortable with the doctor you're dealing with for any number of reasons, everybody has personality types that work better for you. And so even though they may be medical experts, don't hesitate to, as I say, fire them. And get them replaced with somebody that you have comfort with and you're going to really follow carefully with. And so those are the 10 best practices that we've taken from what people have seen and done. And so at this point, I'm going to close this screen and open it up to questions. We have some questions that, in fact, have come up from patients in the past. And so I'm going to ask Marty and Michelle to either give us any question you happen to see in the chat list, or some of those questions that we've received in advance of the meeting. And then Mark and I will do our best to respond to them. So Mark, make sure you unmute yourself there and feel free to grab any of these. Marty, Michelle, what do we got?
Okay, so the first question, does the increased risk apply across the board of cancers in general? And what are the other most likely cancers for transplant patients?
Mark, unmute yourself. Mark, you need to unmute Mark.
Sorry, I started talking without unmuting. Sorry.
That's okay.
Yes, unfortunately, you are at risk for multiple kinds of cancer. You know, as a dermatologist, and what the numbers show us from the hundreds of thousands of transplants, skin cancer is the most common, but you are at risk for other cancers as well, colon, breast, and many of them. But for skin cancer, it's absolutely the most common. And it's important to know one key thing. Did you ever have a skin cancer before your transplant? That's sort of a red flag that allows us to, you know, identify people that we need to pay closer attention to. But you are at more risk of skin cancer, you know, at much higher risk. Like, for example, you guys have heard, you know, squamous cell carcinoma. I think it was mentioned at least once. You know, you're 65 times at a higher risk of getting a squamous cell, 10 times more likely to get a basal cell, and 3 times more likely to get a melanoma. But again, you know, these aren't death sentences. These are things that can be handled and treated in almost all cases if caught early.
One of the other messages you're going to get from this website is that the incident of other types of cancer. Personally, for example, back in 2000, so I'm a cancer survivor of over 20 years from prostate cancer. Back when I was 50, I really didn't focus on this. What man wants to go in and have a prostate check? Let's face it. But because of the transplant blood work they do every year, there was something called a PSA, and that number came back high. And when they addressed that to me and said, you need to see a urologist, my question was, what's a PSA and why would I do that? Well, when they explained it to me, I went to an expert, and I got to tell you something. He was an expert. I didn't like him at all. He thought he was God, and he was going to do this and he was going to do that. I'm saying, sorry, no, I know it's slow growing, but I am a transplant recipient, and things like that work differently in my world. And so we did the gold standard, which is a prostate biopsy, not a fun process at all. The only way you're going to get it. Did a couple of those, and they can be very painful as they take samples from this walnut-shaped prostate. But eventually they were able to identify it. And then with a very simple regimen of radiation, we were able to treat it. And it's been not an issue since. Now, the second time I faced a different kind of cancer, and skin cancer has been my most common, all right? Second time, again, was proactive from one of that network of transplant specialists. And he did some scans and came back and said, Jim, we see something on your kidney that is of concern. And so they went in, and sure enough, there was cancer on one of the kidneys. They did a partial nephrectomy, which means I still have 2 kidneys left, one full one and 1/3 of another one. And that has not been an issue since. Again, caught early, no obvious symptoms. Only reason we caught it was because I'm a transplant patient and they do more careful stuff. As far as Mohs surgeries, Mark, I asked the last time I was in there in preparation for this meeting, I've had 27 visits with Chris Miller, and most of those are with multiple Mohs surgeries. And so I don't know how many Mohs surgeries I've had, but right now I'm still recovering from one on my wrist, or my back of my hand rather, and my ear. I go back and see him next week for some others that they've identified, and I have 3 more appointments. So when you see on a 6-month cycle, for example, an exam. People like Mark are going to find things that you don't think are very much of an issue, but they're going to take care of them for you. And so you may end up with 3 or 4 appointments following that checkup to get rid of this stuff if it takes the surgery. Otherwise, again, Marty mentioned using Efidex as a treatment, a cream, and other ways of doing that. So the most common is skin, and that's why I've talked so much about it, but all those other ones, which are often without symptom, are part of the ongoing practice of preemptive testing, such as a colonoscopy. I mean, I'm finally at the age where they say you don't need them anymore. I'm following that, but at the same time, I'm not sure I like that idea because I'm 78, but I plan to live to 90. So maybe I need to have it checked. So anyway, the answer to that question is there are multiples, and every individual is different, and the different organ types have different occurrences at higher risk than others.
Okay.
Marty, another question?
Can I ask a question?
This is, let me keep going through the questions in the chat feature. And then once we exhaust those, if someone else has a question, then you can ask it at that time, okay? This is a very common question. Can we go to a regular dermatologist, or should we go to someone who specializes in transplant dermatology, Dr. Mark?
That's a great question. I think the best transplant dermatologists work in a collaborative way with regular dermatologists, because we're just not all in a position to be able to see transplant dermatologists. There is an organization called the International Transplant Skin Cancer Collaborative, ITSC. I'll send you guys the link. I'll put it in the thing. And you can actually, in the chat, you can actually see if there is a transplant dermatologist in your area. And almost every area has a few. But it doesn't have to be exclusive. You can see your regular dermatologist in conjunction with a transplant dermatologist. Maybe you see your transplant dermatologist twice a year, but you see your regular dermatologist 3 times a year, or you alternate. Sometimes that can be tricky because you need to have good coordination of care. But one of the best things we were able to do in what we studied was we started a multidisciplinary collaborative transplant dermatology clinic. And the best outcomes were when we were able to work with the transplant nephrologist, with the transplant, cardiologist, in conjunction with medical and surgical dermatologists, because we're talking about skin cancer. Sorry, I need to, my phone's ringing. We're talking about transplant skin cancers, but there are other things beyond skin cancer that need to be addressed. And we're not all at risk, at the same risk for skin cancer. So there are often different rashes that pop up in after your transplant. And sometimes you need a strong medical dermatologist to handle that. But a good transplant dermatologist can help steer you and get you in the right place. There's no reason why you can't see both. But we do provide, as transplant dermatologists, we do provide a unique set of expertise. But you can see others as well.
Next question.
The trap that I did, as I shared, of going to local dermatologists and realizing I didn't really want them to do it in depth. I mean, just being honest about it. And more recently, I did find that the transplant doctor who does the Mohs surgery, there were other things I could go to a local dermatologist for and get treatment for. So I agree with what Mark's saying. Both is the answer. Neither one or the other is the only answer. Go ahead.
Thank you. The next question: what minimum amount of SPF is ideal for post-transplant recipients? And does it matter if it's chemical or physical sunscreen?
Great question. I'm going to try to do rapid answers so we can get to more questions. But SPF 30 is the minimum that you should be using as a transplant patient. There are 2 types of sunblock: chemical sunblocks and physical sunblocks. Chemical sunblocks rely on a chemical reaction to block the sun rays and the ultraviolet rays, whereas a physical sunblock is literally a layer of a material, usually zinc or titanium, that prevents you from getting a lot of UV exposure. My first choice and preference is a physical sunblock, zinc or titanium-based sunblock that's at least SPF 30. You should not waste your money on anything higher than an SPF of 50. So this 75, 100, all that stuff that's out there, in my opinion, and the data show that it's really not much adding much benefit beyond an SPF 50. The key is that you can't just put sunscreen on once and say, whoo, I'm done, call it a day. It's got to be reapplied if you're out, if you're sweating, if you're swimming. So probably every 2 hours, which sounds like a lot and can be exhausting, but every 2 to 3 hours, or you need to at least be setting alarms on your phone. Hey, it's been a couple hours. What have I done? Have I been sitting in the shade? Okay, maybe I can hold off. Have I been swimming 4 times back and forth in the pool and the water? Boom, reapply your sunblock. But I do prefer the physical if you can. Some people have allergic reactions, and some people who say, oh, I don't like sunscreen. It bothers my skin. I get rashes. Well, those are usually from chemical sunblock. So then switch to a physical sunblock and try that. If you care about the environment and you've heard about so many things about ocean and reefs and things like that, you know, sometimes the physical sunblocks are better for those situations. Great. Thank you.
Next question. I've heard that out of the several anti-rejection drugs, it is I'm not going to say this right, mycophenolate that is most responsible for the increased risk of cancer, more so than tacrolimus. Is that correct?
Not exactly, no. So there are 3 buckets of drugs. We have highest risk, medium risk, lowest risk. So you all know what medicines you're on. That's the best thing about transplant patients. They know everything. They know exactly what day the transplant was. They know when their what medicines they're on. They know it all. And so cyclists,
or their wife does,
or they have it written down, or yeah, they've got it. Highest risk, cyclosporin, azathioprine. If you're on those drugs, you really need to be seeing a transplant dermatologist. Second bucket, mycophenolate mofetil, also known as Cellcept, and tacrolimus, Prograf. Those are in the same risk category, medium risk. There is a little bit of difference between mycophenolate mofetil and Cellcept and the Prograf. In fact, actually, I think that Prograf has a slightly higher risk than the mycophenolate mofetil, but it's splitting hairs at that point. Those are in the same bucket, and you don't need to worry about that if you're on either of those 2 drugs. And then the least risk are the newer agents. They're called mTOR inhibitors, sirolimus and everolimus. And if you're on those, then you're at the lowest risk. And some of them have and those are believed to have anti-cancer effects. But the bottom line is you should know what your drugs are so that when you go in, you can have a meaningful conversation. And a good dermatologist or transplant dermatologist will ask you what drugs you're on. Will ask you, have you had your dose lowered or higher? Why have there been changes in your immunosuppression? And we start to think, even though we might not always mention it, we start to think, how many skin cancers has this person had and what is their immunosuppression? And do we need to make some adjustments? Now, dermatologists, I personally believe, should never make adjustments in the immunosuppressive regimen because we don't know. We need your transplant team to make those adjustments, but we often call them and say, hey, guess what? You know, Jerry's had a couple of skin cancers, or Bonnie, she's got 3 in the last month. Is there something that can be done? Is there room on the immunosuppression to adjust? Or we might start adding things to lower the risk because let's say we can't change your immunosuppression because we can't turn things off. You know, obviously you need that organ to keep going, but it's a balance. But you're right to start thinking about which ones you're on and where is your risk category.
Thank you. Gwen was asking, where do you find a good dermatologist skilled in transplants in Maryland?
I'm going to give you that link. I'm going to give you that link. Should I just put it in the chat?
That will be great. And then we can certainly send it out to everyone. But both of our transplant centers, Gwen, have transplant dermatologists, University of Maryland and Johns Hopkins. And she also asked, where do you go to get screened for cancer? I don't know if she meant other than skin cancer, but that's the question.
Yeah, so where you go, you really need a good captain or what I call a traffic cop. And your transplant team is your traffic cop. They are going to tell you, okay, you need a colonoscopy. Okay, it's time for a PSA. Or when was your last mammogram? And do you have routine visits with your gynecologist? You're not supposed to know all that. Now, the website will help you, that you just went through, will help you formulate your questions and trigger questions. but it's a lot of burden to put on a patient to say, you need to make sure you're getting all your all your cancer screenings. Well, how would you know what to get and when to get and what is most appropriate? It's very difficult to know. And there is a balance, right? You can't just be having radiation every week, every month, because that puts you at increased risk. You're already at increased risk. So we want to be strategic about when we're doing screenings. And your transplant doctor should be the one guiding you on where to go. So your transplant nephrologist, your transplant cardiologist, this website, use each other as resources. Find a match among you that you're, same age, same transplant. I mean, there's 50 people here. Some of you look at the patterns among you. Hey, my doctor said I should get a, PSA. Did yours? And start to figure out ways that you could advocate for yourself. To ask those questions. It's very difficult there's no exact formula. And that's also part of the problem. We've only recently in the last 10 to 15 years figured out that transplant patients now live very long, healthy lives. And some of these issues weren't an issue 20 or 30 years ago, but with so many advances in the transplant medicine, now we've realized, we got to start taking care of some of these other things. So, but your transplant doctor should be driving that discussion for you.
I'm glad you brought that up because I actually thought my primary care physician was the traffic cop, but my primary care physician, didn't do the transplant. In fact, she's not even related to the University of Maryland. She's out of a different group. So,
but some primary care doctors are really good at paying attention to this, but transplant physicians are almost like your second primary care doctor, right? They do know a lot about your medical history and they're seeing you so often. Right. And the key is somebody you have a good relationship with, because once you have a good relationship with your doctor, you can start to have meaningful discussions. If you're going to your doctor and you're uneasy or you're nervous or you just feel like you can't ask, then you're not really in a position to get the best care. So like Jim said, you've got to have the key is just having a good relationship with your doctor. And let's assume they're competent, but after that, let's have a good relationship with your doctor so you can get the care you need.
Thank you. Next question. Please talk about using niacinamide 500 milligrams twice daily to help reduce the number of skin cancers. My dermatologist had recommended it and it has proved very helpful to me.
We do use that. So that's out of an Australian study that showed, and we're all lucky we don't live in Australia, by the way, because the skin cancer there rates are much higher, especially in transplant patients, but we learn a lot from them because of that. This is a study that came out of Australia, and what it showed is that nicotinamide, or vitamin B, essentially reduce the number of squamous cell carcinomas and the frequency and rate of development of squamous cell carcinomas. So in some patients, and I monitor, I have a list. How many skin cancers have you had? And sometimes I quiz the patients. How many have you had? Do you know? And they sometimes know, and sometimes they don't. But if the rate is above a certain threshold, or if some of them are what we call high risk skin cancer. So not all skin cancers are created equally. Some of them are high risk, some of them are low risk, depending on some features about them. But if you are at a rate or at getting high risk skin cancers, that's one of the first things that we augment your regimen with is a vitamin B, 500 milligrams, taking it twice a day. But I do not recommend you do that unless you've cleared it with your transplant team.
Okay. And the next question has words in it that'll be difficult for me. This is why I was never a pharmacist. After 10 years with a fantastic kidney transplant, I was diagnosed with a blood cancer and NHL last year. In particular, I have the subset post-transplant lymphoproliferative disorder. How common is this type of cancer and what is the prognosis?
I have seen this type of cancer. So again, this is not a skin cancer, but this is an example of another type of cancer you can get. So this post-transplant lymphoproliferative disorder is definitely something that I've seen in the medical history. Having certain types of blood cancers independently puts you at higher risk of skin cancers, particularly something called CLL. But these are things that have treatments. It's not dermatology-based treatment, so I don't have a ton of information about the specifics of the management of those, but they are not I wouldn't say they're common, but they're not uncommon. And they are something that is, that can be managed, especially when they're picked up early.
Mark, if I can add to that, that is a subject that we've got a lot of detail on the website. Again, some of these issues you may not be interested in until you face it somehow, but you need to know that it's there. We work very closely with some blood cancer researchers, for example, and PTLD has quite a bit of information out there to supplement what Mark just said.
Thank you. My husband had a heart attack almost 5 years ago. He has 2 stents in his main artery. He has 2 spots on his face. He's being difficult about seeing a doctor. What can I do or say to encourage him to see one? And she's seeing them grow. She's seeing the spots grow.
Mm-hmm. You know, one of the things about providing care is meeting patients where they are. And again, not all skin cancers are created equally. And there's a little harm that happens from a conversation. So I always tell patients, just because I see something doesn't mean we have to do something about it now, but we should know what we're dealing with. And we can come up with a plan that we can all agree to. You know, now in the age of telemedicine, maybe this person would be willing to not go to the dermatologist, but would they be willing to have a televisit with a dermatologist? And that could be a way to have a meaningful discussion, you know. And so, first of all, a heart attack, I'm not trying to minimize a heart attack and a stent, but that's not at all a contraindication to treating a skin cancer, especially if you've had an intervention and your heart's on its way to recovery. Are those 2 things on your face basal cell or are they squamous cell? If they're basal cell, we can take a deep breath and perhaps pause. And maybe that'll be the answer. Are they squamous cell? Well, what kind? Do they need to be treated quickly or can they wait a little bit? So it would be great to just have a conversation with a transplant dermatologist that can help put it into a category or a level. But burying your head in the sand is not always a great idea. And having some information, maybe you biopsy it, but you don't treat it, is an answer for a short period of time. But I guess I would say have a discussion at least.
Thank you. I think you answered this. What is a physical sunblock?
Yeah, that's basically, zinc or titanium.
Right. And someone else is asking, where can I find that drug comparison on pre-transplant? Maybe they were talking about the transplant medications.
You can probably find that at the same link that I'm going to send about the International Transplant Skin Cancer Collaborative. I can look there and I can try to send you a link so that you can see the buckets of immunosuppressants.
And
we're
that's
going to have whatever Mark gives us there, we're going to put up on the website so that everybody can access it there whenever.
That's great. That's all of the questions that were in the chat room. I don't know if anyone else has any questions. And as far as the polling questions,
I see people talking, but they're muted. If you're talking, you're muted. Yep.
Yes, thank you so much. I just have one quick question and wanted to know, could you give a basic description, a general description of how some of the cancer or 1 or 2 of them might appear on the skin? Would a basic new mole be an indication of it? Or how would that mole appear? Would it grow real big or etc.?
Those are great questions. It depends on your skin type. So let's just back up for 1 second. So 75% of skin cancers in transplant patients happen on sun-exposed skin. So those are the areas that you should look for first. So that means 25% of skin cancers happen on non-sun exposed skin. So the areas where the sun don't shine, genitalia, buttocks, under the undergarments. Now, most skin cancer does one thing and one thing only. It changes. If you have a spot on your body that is not changing, it's not skin cancer. So if it's changing, that is the most important thing. Now, you are allowed to have new moles up until you're age 40. After you're age 40, if you get a new mole and it doesn't appear and just stabilize, especially if it's changing, that's something we want to know about. So I'm just going to be real brief about what to look for. For basal cell and squamous cell, which are the 2 most common types, what you should look for is a sore that won't heal or a pimple that's unusual in that it sticks around for a little longer than what a pimple should stick around for. If you were at all suspicious, you go to the dermatologist and have it checked out. So those are for a basal cell and a squamous cell. For a melanoma, it's an irregularly shaped mole or a brown spot, or sometimes a pink and a brown spot. Now, oftentimes people will come in and point out those things and they're not skin cancer. So just because you see one of those things, there are other benign things that have those features as well. But that's why you need to have a check by a dermatologist. Now, the other thing we need to talk about are viral induced skin cancers. And sometimes those happen in the genitalia. It's basically a transformation of a virus into a skin cancer. So we've heard about HPV virus. Those can, in transplant patients, people who have had HPV, those lesions can turn into a skin cancer. And those don't quite follow the same rules because they're not in sun-exposed areas usually.
We have much too short a time today to really give more depth to those answers, but the website has an awful lot of skin cancer because it's so common, and a lot of pictures that would complement what Mark just said about those different types that you're looking for, along with explanations as he's just highlighted. So go to the symptom stage, the look section, look up skin cancer, and you're going to have enough there to keep you busy for a while to complement what Mark has just advised. Michelle?
I do have another question. Is the tanning bed just as bad as the sun?
Worse.
So
way worse. Way worse. You should never, any of these, no regular patients should not be in a tanning bed, and certainly transplant patients. The amount of ultraviolet light is concentrated and delivered at such a high dose that the tanning beds are a known carcinogen. They are classified by the World Health Organization as a cancer-causing agent. I mean, there's just nothing to even say about it. It makes our blood pressure go up.
Whoa. Well, that is great. And you had us do these polling questions, Jim. Maybe people would like to know the most common answer. For the first one, when were you made aware of the higher risk of cancer as a transplant recipient? The most favored answer was number 2, post-transplant or in the follow-up process. For polling question number 2, as a recipient, what types of cancer have you experienced since receiving your transplant? Actually, number 5, none was the most common answer. And number 3, as a patient, how often do you get screened for cancer post-transplant? The most common answer was once a year. Everyone has said excellent session, great information, a lot of information, useful information, very interesting. Thank you, Dr. Mark. Thank you, Jim. So there are all of the comments also in the chat feature.
Michelle, if I may, I have 2 more slides to close out the session. Would you mind?
We have to charge you now, Jim. It's after 12 if you're going to show more slides.
Or you have to be providing lunch for all of us.
Well, go to the store and just tell them that Jim sent you, right? Basically, all I want to do is say thank you to Trio Maryland for hosting what is obviously a very engaging and interesting topic, very important topic. And don't forget that website address. And then finally, join Trio. If you're out there and you're not already a member, we do things like this. We're out there really giving back for the gift of the donation of an organ that saved our lives. And through Trio, you can multiply the ways that you can help others. So join Trio Maryland, join any of the chapters. You can find the chapters at trioweb.org, and we welcome you across the country. And there's also, if there's no chapter local, we do host members at large. And that gets me back to you, Michelle. Thank you.
And the little piece I like to say before we leave, I think we were all taught by the fire departments in our neighborhood that when we change times in the springtime, you got to change the batteries in your smoke detector. I think we ought to start a new tradition. Once we start having more sunshine, we should all buy ourselves a new summertime hat.
And my dermatologist says if they're not laughing at your hat, it's not brimmed enough. You need to have enough brim to make it really funny.
That's right.
Thank you, Mark.
Well, thank you, Jim Gleason. Thank you, Dr. Mark. I'm not going to butcher your last name again.
Yeah, thank you for having me. It's a real pleasure. Happy to do this and do more of these. I think it's a great learning tool and really a motivational way to get better care.
And none of this would be possible without all of you. I want to thank everyone, all our TRIA members, all our guests. If you have any questions, please get a hold of one of us. But thank you so much for attending today. I hope that you take it forward and use that information to the good.